It may not always be easy to see the link between EMS and trauma care and public health, but the two systems have worked together on several projects that have improved the overall health of our state. For example, 15 years ago, a handful of visionaries, many who are in the room with us today, set about creating a voluntary, data-driven EMS performance improvement initiative to improve survival from cardiac arrest. This led to a threefold increase in the survival rate for people who suffer cardiac arrest. Public health and EMS worked together again and applied the model cardiac arrest care to teach 911 dispatchers to rapidly coach telephone CPR. This also led to an increased survival rate of those who suffer from cardiac arrest. Today, we are proud to share another partnership between public health and EMS, improving traumatic brain injury outcomes for the most severely injured patients. Traumatic brain injury affects thousands of Arizonans each year, many of them young people. These injuries can have lifelong consequences. Thanks to the work of this project, we are improving outcomes for these patients, not just in Arizona, but around the country and likely throughout the world. Arizona is once again leading the way in developing groundbreaking projects that will improve the health of our communities and save lives. The announcement of these study findings is another example of meaningful collaboration between public health and our community partners. I would like to recognize Dr. Ben Babra, who has been the EMS Medical Director at ADHS for 15 years.
Thank you, Director Chris, and distinguished guests. Good morning. For the last 15 years, the University of Arizona, the Arizona Department of Health Services, and Arizona's fire and EMS agencies have partnered to improve outcomes from critical, time-sensitive medical emergencies. Together, we have implemented novel CPR programs and techniques that have quadrupled survival from sudden cardiac arrest and have saved more than 4,000 lives in Arizona. These efforts scientifically prove that high-quality pre-hospital care delivered on scene long before people are able to reach the hospital are key. Seeing the success of our earliest efforts to improve cardiac arrest care, in 2010, the National Institutes of Health funded our Excellence in Pre-Hospital Injury Care, known as EPIC initiative, a unique statewide collaboration evaluating the pre-hospital TBI guidelines for the first time anywhere in the world. The program's success has truly fixed Arizona's place as an international EMS leader. It's difficult to overstate the burden of traumatic brain injury, TBI, in Arizona and in the US. Tragically, 52,000 people die every year from TBI in our country, and many, many more suffer long-term disability. TBI impacts kids and young adults the most and is now the #1 leading cause of death under the age of 40. In addition to exacting a huge toll on our citizens, TBI often devastates the brave, uniformed men and women protecting our country. In Arizona, there are more than 3,000 TBI cases every year. That's 8 people today. The economic impact is enormous. TBI costs our country over $60 billion every year. TBI is now responsible for more years of lost life than heart disease, cancer, and stroke combined. The scope of EPIC is massive, enlisting more than 130 EMS and fire agencies and covering 93% of Arizona's population. Since 2012, the EPIC team, led by Bruce Barnhart and John Tobin, has certified more than 600 master trainers who have in turn trained and certified over 11,000 frontline EMTs and paramedics. We commend our EMS professionals for this tremendous achievement and for the life-saving care that they provide every day. Please acknowledge them. The TBI guidelines call for 3 important changes to conventional treatment, as Dr. Robbins was just describing. It is essential to avoid what we have termed the 3 H-bombs, physiologic derangements that devastate the injured brain. The 3 H-bombs are hypoxia, or low oxygen level, hypotension, low blood pressure, and hyperventilation, ventilating too fast. Hypoxia can happen when a TBI victim's brain is so injured that they aren't breathing normally. In such cases, levels of oxygen in the blood drop perilously low, and rescuers are not able to give enough oxygen to patients. Hypoxia is harmful to injured brain cells and dramatically increases the risk that they will die. Hypotension is common when multi-system trauma patients also suffer injuries to other parts of their body, such as the chest or abdomen. If patients are bleeding from these injuries, their blood pressure can drop dangerously low. With the rapid insertion of IV lines and infusion of fluids, the hypotension can be improved or even prevented altogether. Such treatment keeps brain cells alive while patients are rapidly transported to trauma centers for definitive care. Hyperventilation, or ventilating too rapidly, is hazardous and almost universal in everyday practice. When patients are severely injured, they often need assistance with ventilation. Rescuers insert a breathing tube into the windpipe and attach a breathing bag to the tube. EMS agencies in Arizona now use a special ventilation bag that controls the flow of air into the lungs with a light timer, which provides the exact rate at which to ventilate both children and adults. Ventilating at the appropriate rate and volume is life-saving. This equipment, which I'm going to show you now, was generously donated to the EPIC agencies by the Ramsey Social Justice Foundation and AMR. Please thank them. You will see a detailed demonstration of this in a moment, but in short, this bag, which appears to be a normal ventilation bag, has a special device that prevents the rescuer from delivering too much volume too fast. You can also see here this blinky light. That tells the rescuer exactly when to ventilate. Without those simple devices, rescuers almost universally breathe too fast and too forcefully. This is an example of how basic equipment that appears simple can have life-saving impact. I want to point out that we use special equipment for EPIC for both children and adults. I would like to acknowledge our Arizona Emergency Medicine Center Research Director, Dr. Sam Kine, for his amazing leadership and guidance. I would now like to introduce my partner, Dr. Dan Spate, who will share the important study results and widespread implications of our collective effort. Thank you.
So I have to, there's one group that I have to say amazing things about. We've already alluded to it, but the people who actually saved the lives were not university professors, were not administrators. The people who saved the lives are the ones who we have the amazing sense almost that the Bill of Rights says you ought to be able to call a simple number and they will show up no matter who you are, no matter where you are. And so I want to make sure everybody understands, out of the severe TBI group that we're going to talk about primarily, they on average were hospitalized for 10 days at trauma centers in Arizona. On average, they spent only 20 minutes with the EMS providers. And you're going to see what the first 20 minutes of brain injury care does to patients of this traumatic disease. So here come the incredible results. What a privilege it is finally to announce the EPIC initiative. Just an hour ago, it was published in JAMA Surgery. There are copies for everyone, I believe, and if not, if you just go to epic.arizona.edu, it's downloadable there. So the evaluation of the EPIC treatment protocol was accomplished by an unusual public health initiative, so that this is not research in any classic sense. There was no randomization. There was no choosing some departments to do it the right way and others to do it the old way. This is, everyone had the opportunity, and as you heard, 93% of the citizens of Arizona benefited from all of these amazing agencies that opted in. And it was called a before-after analysis. So we analyzed those who were cared for with brain injury before we implemented the training, and then subsequent after the training. So it's a before-after evaluation. And in all, as you've heard, there were nearly 22,000 major traumatic brain injury patients. This makes EPIC by far, probably by tenfold, the largest pre-hospital traumatic brain injury project ever accomplished in the world. Congratulations to Arizona. There were about 15,000 in the before, so that would have been the old way, if you will, and there were 6,600 patients, much more now, but at the close of the time of the evaluation, 6,600 patients have been there. And the most striking findings are in those patients who have severe traumatic brain injury. That accounted for 76%, essentially 3/4 of all of these patients. So this is thousands of patients who were in the group that benefited. And amazingly, if you've seen the paper, if you understand what an odds ratio means, think of this. The first 20 minutes of care done right doubled survival in the state of Arizona. This is an absolutely staggering finding. And when you talk about those who had a tube put in and breathed, as Dr. Bobrow was just showing for us, amazingly enough, the intubated severe group, they had a tripling of survival. And so I'll talk in just a minute about the implications of those kinds of changes. Specifically, the focus on the H-bomb that is called hyperventilation is not only counterintuitive. When I trained a few years ago, that was the plan. Put a tube in and hyperventilate the patient. We didn't know at that point that actually we were doing exactly the opposite thing. And now in a gigantic effort in Arizona, we have been able to show the world that preventing hyperventilation, doing exactly the opposite of what we used to be trained, is actually the way to save lives. So just 3 implications that I think are important and will be understandable to all of us. First, the beauty of EPIC is it only involved really simple interventions. This wasn't what I like to call the $1 million unobtainium drug, right? This was very simple. The EMS providers already know how to put IVs in. They already know how to intubate and ventilate the patient, and they already know how to do, the first thing is to put high flow oxygen, what you will get to see in the demonstration behind us in just a few minutes. They already know how to do this. So EPIC actually just taught them how to optimize and do right the procedures that they already knew how to do. Just 3 simple interventions done right doubled survival in severe TBI in our state. So this means that the life-saving interventions that Epic and Arizona have discovered can essentially be done anywhere in the world. This is not a new expensive widget or a very expensive drug. It's something that's really simple to do. The second implication is this: improvements in outcome in medicine and public health are almost always incremental. It's a big deal when you find a new antibiotic that decreases mortality by 10%, right? That's a big deal in medicine now. That makes it top of the line in JAMA. This is, let me put it into to lay terms, this is improvement of 103% in survival. The other thing that's remarkable about this is most outcomes that improve do things like decreasing the amount of time you're in pain, right? Or improving symptoms. This is actually the big one. This is death. And so this outcome is the hardest one to change by far. And amazingly enough, it doubled and tripled in the intubated group. And the third implication is this: you may not be aware, but for 40 years, there have been study after study after study searching for a way to help traumatic brain injury patients. We tried to cool the brain. Doesn't really work. We tried steroids. We tried progesterone. We tried all kinds of drugs that not even I can pronounce. It is literally, think of it this way, it is 4 decades, my colleague Dr. Denninghoff loves to say it this way, 4 decades have a graveyard full of unsuccessful attempted TBI treatments. And now, for the first time in nearly half a century, we can report that we can actually markedly, dramatically improve survival in this horrendous public health problem. So in conclusion, EPIC is the first large-scale evaluation of the pre-hospital TBI guidelines conducted anywhere. It was accomplished through a unique partnership between the Arizona Department of Health Services and more than 130 EMS agencies, along with the University of Arizona. I have to mention that if it were not for the Department of Health Services, this could not have been done. Because a university can't simply go out and say, we're going to change care in the state of Arizona. That's not legal. So only through this unique partnership, really not anywhere else in the country enjoys this kind of public health partnership. This is what has been able to happen. It is very likely that these findings are going to literally make major changes in how traumatic brain injury is taken care of throughout the world. Thank you very much.
We want to make access to the patient as soon as we can. So we have a firefighter go in the back in full protective gear, and they're going to start to address medical needs as well as protecting them from anything that's going on as far as the extrication. So they're going to put a C-spine collar on this person because we don't know if they have any problems going on in their neck or their back. We have one of our firefighters using the spreaders to gain access into that driver's side door. So they're getting the collar on, they've covered him with the blanket so all the glass and stuff that's going on that is coming out doesn't get on them and hurt them. So on the left, we're setting up a little treatment area. They're getting things ready. We know that hypoxia is a big thing for traumatic brain injury, so we're going to be worried about their airway and breathing for them. Hypotension is the next thing, so we're going to start a couple of big IV lines and administer fluids. And then we're going to monitor their end-tidal CO2 to make sure that we're not hyperventilating that patient in any way. Part of the extrication is also getting them from where they are in the car onto a backboard, onto the gurney, and then they deliver them into the treatment area over here on the left, where all the other medical stuff is going to happen. So it looks like they determined that his breathing was not good enough on his own. They're going to assist him with the bag valve mask device. They're using the little visual rate timer, or what we like to call it, the little blinky light on the bag valve mask. So when it blinks, you'll see he squeezes the bag. They're going to hook him to our defibrillator monitor and take some vital signs to assess. For hypoxia, their blood pressure, make sure it's in the right range, and then also their end-tidal CO2 to make sure that they're not being hyperventilated. So what we have taught our members is the first 10 or 20 minutes when we have them is one of the most critical times for a traumatic brain injury patient. So we want to make sure that they are ventilated properly, they're not hypoxic, low on oxygen, they don't have a low blood pressure, that's why we establish the fluid in the lines. And then we want to make sure that we're not hyperventilating them, which is what we used to do all the time, was we get them tubed and hyperventilate them big time.